Okay, today's lecture is going to be on congestive heart failure. If you turn to your Lewis Med-Surg book, page 737, that's where we're going to start. Pretty much this lecture is going to be based on knowing what heart failure is, the reason for heart failure, what the pathophysiology is, showing some of the signs and symptoms of heart failure, depending on right or left, and also looking at diagnostic studies with blood work and also radiology. And then as far as the rest of it, we need to know how to treat someone who is in congestive heart failure and try to make them better. CHF is really not a disease process, but is caused by things such as high blood pressure, and things that contribute to that, such as smoking, stress, different kind of risk factors that may impact heart disease. But usually what happens is over time the person begins to have plaque build up in the vessels, and eventually what happens is you end up with coronary heart disease, and eventually the heart does not pump like it should, so you end up in congestive heart failure. Like I said, heart failure is not a disease. It's a group of manifestations that affects the heart pumping mechanism. If we look at congestive heart failure, four essential elements are important to the heart function itself. So you have to have contractility to the myocardium. You also have preload, and that's before the vessels or the ventricles go into diastole after they eject the blood. And then you've got afterload, and that's how hard the body has to pump against the force to reach the circulation. So we've talked a little bit about left ventricular hypertrophy, and I've talked about the different things that concern me as far as athletes, because the use of protein drinks and things like that can actually cause an increased muscle, which in turn will cause problems with the heart contracting or contraction of the heart. So therefore it leads to congestive heart failure. And also another element would be the heart rate, how fast it is pumping, because remember, if you have a higher heart rate as well as a higher blood pressure, problems can occur because your atrial kick does not produce enough blood, which is oxygenated, to the body. So the normal heart automatically responds to maintain the cardiac output, and that's through these different things, as the preload, the afterload, how it contracts, and the coordination pattern of the contraction, and also the heart rate. Causes of heart rate can be divided into three different groups. Of course, you've got abnormal loading conditions, which means the preload and the afterload can affect how the heart pumps itself. And then you've got a problem with the muscle, in which maybe the heart has had damage to some portion of the heart itself, or it has extra muscle to where it's thick, so it doesn't actually contract like it should. And then you've got other disease processes that can precipitate or exacerbate heart failure. One of the ones that comes to mind with heart failure, like I told you before, usually you'll see atrial rhythms such as PACs, atrial tach, atrial fib, atrial flutter. And the one system that seems to deal with this problem or disease process would be your thyroid disorders. So CHF results from damaged heart muscle. Either you can have atherosclerosis, congenital heart defects, high blood pressure, pulmonary hypertension, which occurs from things such as liver failure, pancreas problems, anything with the gallbladder usually affects that and causes pulmonary hypertension. You can have MIs, which affect the muscle itself because some part of the heart muscle itself will die. And then, of course, you've got valvular disorders, because when your valves don't pump efficiently enough, then you've got problems with having a forward flow of blood, which causes a regurgitation and causes pressure buildup and increased muscle thickness. Terms, like I said, preload is the force of the load of blood coming to the ventricles prior to the contraction. So you've got all the blood that goes through the heart, through the atrium, through the valves, and it deposits down into the ventricles. And what happens is, prior to that contraction, it has an extra load of fluid that dumps in. People who have this would be maybe somebody who has maybe edema, you see that, or they might be overloaded with fluid for whatever reason. So what happens is that extra fluid, such like in pregnancy, you have an extra volume, dumps into the ventricles, and it causes an increased distension of the ventricles. So what happens is you have to have a higher force in order for it to pump out. So this in turn affects the afterload, which that's when the contraction begins, and that's how hard the heart has to pump in order to project that blood out into the periphery. Stroke volume, again, is the amount of blood ejected with each heartbeat. Usually what happens is that when your blood comes back to the heart through the atrium, it dumps into the ventricles. That's usually about a 70 milliliter volume for every beat that occurs. So cardiac output is estimated on the amount being pumped out each minute, and it's looking at multiplying it by the stroke volume. So example would be, let's say my stroke volume is at an average of 70 milliliters a beat, and my heart rate is 72 beats per minute. So what you get is a volume of 5 liters that go through the heart with each heartbeat. So again, conditions that precipitate or exacerbate heart failure would be physical or emotional stress, increased sympathetic nervous tone, and catecholamine releases. So anytime you increase emotional stress or physical activity, what you're doing is you're actually causing an increase in heart rate, so therefore it does affect the cardiac output. So again, if you go back to the last slide and you look, stroke volume times cardiac output, or stroke volume times pulse, it's going to increase how fast and how hard the heart has to work in order to keep up with that stress. So eventually what happens is, with this prolonged period of time with physical and emotional stress, so if you have someone who has extra stress in their life, which none of us do, then you over time build muscle in the heart, and you will increase that cardiac output, or decrease that cardiac output, excuse me. Also, just to let you know, some of the things that can cause congestive heart failure are any type of infection, systemic infection, which we'll talk about in another lecture, but anything like sepsis, anything that increases the oxygen demands of the body itself, which in turn speeds up the heart rate, which increases the muscle mass of the heart, is going to cause problems and can cause congestive heart failure. Another thing that possibly could cause congestive heart failure is anemia, because the body's response is to try to produce more red blood cells from the bone marrow, and then what happens is you have an increased volume of blood inside the vessels, and then again that affects your preload and your afterload, which in turn affects your cardiac output. So it can be a vicious cycle if things are not taken care of, which you all are studying anemia right now. But, not only does anemia cause increased heart rate, it also causes muscle pain and can mimic, actual myocardial infarction because of the chest pain issues. Like I said before, thyroid disorders are a biggie in congestive heart failure. So anytime you have someone who comes in with congestive heart failure, as a nurse and as an advocate of the patient, if they have not been tested for thyroid disorders, you might want to delve in to ask the physician, hey, could we possibly order a thyroid disorder or, a TSH? Pregnancy is another one that can cause problems. Nutritional deficiencies, actually vitamin B12, affects with the cardiac functioning and can cause dilation, which, pulls the blood, increases the cardiac output, or, the stress of the heart. Pulmonary disease, another biggie with congestive heart failure is COPD. What happens here is you have an increase in the pulmonary pressure in the pulmonary system, which can actually cause pulmonary embolism and pulmonary hypertension, which those things, when you have COPD, are very hard to treat. Another thing that you could have that could cause congestive heart failure would be hypervolemia. And again, this is the excess of the fluid on board that the heart has to deal with. And in turn, it increases the muscle mass of the heart and decreases the cardiac output. So the pathophysiology. The myocardium of the left ventricle may either be diseased or it may not be able to meet the circulatory needs of the body. So this is what can cause congestive heart failure. So when the body senses that it is not getting what it needs, it does compensation issues, and that's when failure is first noted. So usually when you go into congestive heart failure, heart rate speeds up, blood pressure, usually drops eventually, but immediately you may not see any signs and symptoms of congestive heart failure at all. So what happens is the body tends to compensate for lacking of needs, and so you will end up starting to see tachycardia and increase in blood pressure initially. And so when these mechanisms fail, the amount of blood remaining in the left ventricle at the end of diastole increases. So if you go back to your terms, preload and afterload, you have a preload problem as well as an afterload. So in turn, this increases the muscle mass of the heart and in turn causes a decrease in cardiac output. So things become stasis and you end up with pulmonary edema and fluid that pulls in the extremities. We've already talked about this, that, anytime you increase the workload of the heart or anytime you increase volume, you also begin to cause hypertrophies, and this is when you have a displacement of the PMI. That, normally the PMI is located in the fifth intercostal space, midclavicular line on the left side, but what happens over time, that muscle mass builds, and so you have a hypertrophy, and the PMI shifts down to the 6th or 7th intercostal space, telling you, as far as assessment, that you could potentially have a problem with some swelling. Okay, we've already talked about this slide, so we'll move on. Because of the increased pressure, again, the pulmonary vascular system dilates, and eventually, you have failure of the heart, and in turn, you're going to have failure of the respiratory system, which in turn, if you have congestive heart failure, it really affects all the systems of the body. So therefore, when you're doing a person who is in congestive heart failure, you need to do a holistic assessment on these people. So pretty much after you have engorgement and you have a long, prolonged situation where you have increased fluid on board, what happens is your afterload and your preload increases, and then you have a backup into the right ventricle of the heart, and thus you have right-sided heart failure. So right ventricular failure usually follows left ventricular failure. So when you're looking at the difference between signs and symptoms, they can pretty much mimic each other because, like I said, if you have left ventricular failure, you're going to have more problems in the respiratory, whereas in right ventricular heart failure, you're going to see more systemic problems such as swelling in the extremities, etc. But usually when you start to see that, you can pretty much say that, left ventricular hypertrophy has occurred, and therefore it's causing a systemic problem. So if I'm just looking at right-sided heart failure, usually what comes after the right side is the pulmonary system. So anybody who has pulmonary diseases or COPD or cor pulmonale, that usually is going to indicate that you have right-sided heart failure. But over time, left-sided heart failure will occur. Okay, I think you can read that slide. Nothing too much to talk about there. But looking at the classifications, the New York Heart Association has a classification of heart failure, which I think, if you look at this, it is on page 741 in your book, not 1653. But it talks about the activity of the person, and this is how you can classify someone as far as their heart failure. So if you had a CHF class 4, obviously they're not going to be able to do too much, especially when you're bathing them. It probably might take you 2 or 3 hours to get them completely cleaned up for the day. But usually the symptoms at this point are at rest. You don't have to really do any physical exertion to cause problems with symptoms of CHF. Would be like shortness of breath, of course swelling, coughing, and maybe even feel like you're suffocating. Heart failure descriptions, I think we've already gone over that. I don't need to you can read that slide. And we've talked about, depending on which side is at risk or at failure, that's the kind of symptoms you may see. So even though only one side of the heart may be responsible for the initial failure, long-term failure usually involves both sides of the heart. I'm going to let you go ahead and read this, the acute compensation of the heart failure, that you've got the sympathetic nervous system involved, and if you have not or don't know too much about the Frank-Starling law of the heart, then you may need to review that just for your own knowledge. But you see here you've got sympathetic stimulation, which increases the heart rate and often produces tachycardia. And just because you have a high heart rate, it increases the muscle because over time it strengthens and causes an increase in muscle mass. So we've got to watch out for people who have chronic tachycardia. Always people who have coronary artery disease are at risk for congestive heart failure. And that's why, as nurses, we try to educate the client or the patient, whatever you want to call them, to decrease the risk factors in order to prevent congestive heart failure in these people. The whole goal of congestive heart failure is to keep up with the demands of the body and to reduce the workload of the heart. So that's basically what you're trying to do. We've already talked about this when we first talked about the coronary arteries, that they supply the blood during diastole. So when you have a high heart rate, your diastole is cut significantly, and so therefore your coronary arteries are not supplied with the oxygen and perfusion they need. So therefore over time they become sclerosed, and so the heart does not beat like it's supposed to. So again, that goes back to the elements of congestive heart failure, where you have the inability of the heart itself to pump. So in turn, when you have this situation, you're going to have problems systemically because the body is not perfusing the other organs that it needs to. So you're going to start to see multi-system organ failure is what will eventually happen with this. I think we've already talked about that. You can read that. You can read this. Constrictions of the veins, we've already basically talked about, the constriction. You're not going to get the perfusion of the vessels like you should, and of course it increases the right atrial pressure, which decreases the atrial kick, and in turn causes tachycardia, etc. So if you just sit down and think about this, it makes sense. Anytime you're speeding the heart rate up, you're making it work harder, and it's just like exercise. When you exercise, you build muscle. That's the whole goal, is to get rid of the fat. Okay. So in summary, again, you've got depressed cardiac output following acute failure may approach normal levels as a result of the different body's mechanism to try to compensate for that lack of cardiac output. People who actually are in congestive heart failure can actually have a normal functioning of themselves based on that New York Heart Association where they classify. And some people, don't have that severe of congestive heart failure, so they can actually function until, it advances. The main goal as the nurse is to try to reduce the risk factors and trying to promote health to the best of your ability and their ability. So complications, again, pretty much if you lose the ability to contract your heart because of the heart enlargement, pretty much your body in general is not going to be perfused. So you've got to watch these people, because even if they're in congestive heart failure, we think of increased fluid on board, and you would typically think that because of that you would have, yes, a high heart rate, but yes, you would have a high blood pressure. But ultimately what happens is, your vessels constrict, or dilate rather, and for whatever reason your blood pressure drops. So again, you're not perfusing the organs that need to. So eventually what will happen, these people will be FTD, and if you want to say, because eventually that's what it will lead to if you don't treat the symptoms and the problem. So acute pulmonary edema is a medical emergency. Usually this results from left ventricular failure, and so what happens is you have pressure that becomes so elevated inside the pulmonary system that you have little blood vessels, alveoli, bronchi, that seem to bust, and this is where you get your frothy, bloody sputum. So anytime you see a high heart rate, probably a low blood pressure, and it could be high because, it depends on what stage of the compensation situation you're in. You could actually have, this bleeding. So what happens is, these vessels bust and they spit up this frothy sputum, and eventually what happens is they tell you they're real anxious when they're in this situation. It's almost like you can't even calm them down. And then the fact that they're coughing up blood is not good either. So eventually what happens is you get pulmonary edema. Usually it causes death from suffocation, which is not a good feeling if you've ever been choked before, because it's not a good feeling. If you think about people who have COPD or asthma, if you were to take a straw, just a drinking straw itself, pinch your nose and try to breathe through that, That's exactly what it feels like to have any type of respiratory disorder, because the lumen of the airways are actually decreased. So it's almost like literally sucking for air. So here's some of the signs and symptoms of a PE, or pulmonary edema. These people are very, very anxious, and again, because you have, increased pressure, you're going to have the shortness of breath. You're going to probably see these people in what we call a triad position, where they're actually sitting up on their fist or their hands, and they're tripoding to try to get as much air as they possibly can. Due to the lack of perfusion, of course, you're going to see people who are pale, and sometimes, if it's bad enough, you can start to see people who have cyanosis. I know with COPD and CHF, the first thing that you will see is people with perioral cyanosis, and they will do that tripoding position to try to increase the amount of air that they can get. So the prognosis depends on several things. Of course, how well you're making the heartbeat, okay, what kind of cardiac reserve you have, and of course any other disorders that may impact, congestive heart failure. So again, this would be medications, diets, limits on activity, and things that affect those, or the responses to those. Actually, the further you go along, if you can't exercise, if you can't take your medicines, if you don't abide by your special diet, like the low sodium cardiac diet, this can actually signal a poor prognosis. So if we look at left ventricular failure, here's some of the actual symptoms that you could see. Again, these people are very anxious because, again, if you lack oxygen, your neurological status will change. Not only that, when we look at mental confusion, if you think about the blood's way that it presents itself, if you have an overload of fluid on board, that it dilutes the hemoglobin and hematocrit, and also decreases the sodium level. And I don't remember if you remember me telling you that with sodium, its biggest function is mental capacity. So once you start to dilute the sodium, you're going to start to have mental confusion, which comes along with lack of oxygen. So those are two things that impact, with COPD as far as the mental status. Again, right ventricular failure, anybody who's in CHF, these people need to be weighed on a daily basis. And as the nurse or whoever you're delegating this process to needs to make sure that they're weighed on the same scale daily, and that they're wearing about the same amount of clothing that they were the day before, because clinicians base their treatment on weight. So if you don't balance the scales and you don't do what you're supposed to, if you're trying to cut corners because you've got 10 patients and you just throw them on the scale without balancing, that could cause a weight gain or a weight loss, and they may decrease or increase the medications based on that weight. So again, it could be a revolving door kind of thing where you're trying to get the right treatment. So as the nurse, that's one thing you need to make sure that you do, is you're looking at daily weights to see if they've increased or decreased, and making sure it's as adequate as it possibly can be. So the goals, you want to make sure that you're improving ventricular pump performance. Remember that the heart probably over time will be damaged, so you've got to make sure that the body as well as the heart is getting oxygen. And of course, DIG is a big one, and some other inotropes medications can be used as that. You also are trying to reduce myocardial workload. So these people who have congestive heart failure because of the lack of oxygen will probably have angina, more than likely. And usually what nitroglycerin has done is to dilate those vessels so that you can perfuse the body like you're supposed to, so you can decrease the chest pains that you may be having. ACEs are also important, and beta blockers in CHF. These are used to reduce the preload by diuresing and fluid retention. And so, ultimately you're also trying to prevent the reduce of stress, further injury to the vessels. So pretty much you're trying to keep this person from progressing in their, symptomatic presentation. So here's some of the diagnostics that you would see. You've got BNP, which I think my clinical group has seen enough BNPs that are really elevated. I think I have not seen a BNP that has been 32,000 before in my life. And they didn't seem too concerned about it, but when a BNP rises, that's telling you, they're severely affected by the congestive heart failure because of the fluid overload and the work the heart has to do to overcome those issues. You might also see an echocardiogram done, and again, we've talked about reading strips and things like that, different things on the EKG can tell you different things about the heart. Of course, you want to do a chest x-ray to see if the cardiac margins are enlarged or widened, because that signifies that my heart is becoming musculature and the inability of that heart to pump. So you could see ABGs. So you got to worry about acidosis in these people. They've started coming out with lactic acid to try to treat these people, because CHFers can actually have hypovolemia, but they can also have hypervolemia. What happens is all the fluids pull on the outside of the cell, and so you're really dehydrated inside the cell. So in CHF, your electrolytes are very important. So you may strongly recommend that you review your sodium, potassium, calcium, magnesium, your electrolytes that affect the heart. And of course, the BUN and creatinine can tell you how the kidneys are functioning. Again, CHF, you're in organ failure after you've depleted the supply of oxygen. They start to die as well. So the way your body rids of extra fluid is through the kidneys. So therefore, you've got to look at the BUN and creatinine. So here's some of your nursing diagnosis. I'm one of these people that I don't like to look for risk fours. I like to actually look at actual problems. That way you can take care of problems, but you can also look at things that might occur that you can assess for and try to prevent. Those are not the pages, so don't even look at that. Again, with CHF, you're going to see pretty much atrial rhythm problems with this process. So when you start to see PACs, PATs, or atrial tach, atrial flutter, atrial fib, again, the questions you want to ask are, what other disease processes could impact this, especially the thyroid disorders. So I'm going to let you read the rest of this, because here's what PACs, this is what happens. Usually if you let the PACs go, they'll end up causing atrial tach, atrial fib, atrial flutter. And again, electrolyte imbalance occurs with this because of the shifting. And here's some of the symptoms you will feel. Real interesting to note, we had a lot of atrial fib in clinical this past week, and we were actually able to assess the heart rhythm or the pulse, the cardiac or the PMI, the apex, the heart rate, listening to the heart rate and palpating the radial pulse. And actually, you were able to feel the difference. So if you have someone who's in atrial fib, you don't necessarily need an EKG to actually know that they're having a rhythm disturbance. So here again is a PAC. You see my little P waves right here, okay? And right there, you've got a premature contraction, and then things pick up and can become normal again. So when you start to see these, be cautious, because this is signifying that my heart is not doing what it's supposed to do. It's becoming irritable, basically. And here's another picture. You see the P right here where this first era is, and then you have the follow-up of the ventricular contraction. Rhythm here is equal until you have a beat that comes too early. But that whole complex, remember, has a P before the QRS. It's just that that whole complex came earlier than what it was supposed to. But you're able to identify P's, QRS's, and T's. Here's what atrial tach, that's paroxysmal atrial tachycardia, is just what PAT stands for. Here's the different things that it can occur from. Here are your different things that can cause. These are less common causes of atrial dysrhythmias. And then you've got, just describing what PAT is. Here's some things to treat that. You can actually tell them to bear down like they're having a bowel movement. In kids, when they have atrial tach, usually we can put a cold compress on their eyes. And this comes from taking PALS and ACLS, which that gets further into discussion than we want to do today. But usually with atrial rhythms, you're dealing with treatments such as adenosine, verapamil, beta blockers. Sometimes they'll use sedatives, and if the person becomes so symptomatic, they do cardioversion. And usually that's scheduled so that they have all the necessary equipment there in the event that when they do cardiovert, a person could actually have a stroke depending on how long they've been in that atrial rhythm. So usually they try to plan that cardioversion, so that all of your necessary, like I said, equipment and your personnel are available in the event something bad happens. Here's PATs. Remember I told you, or you can say atrial tach. Remember the heart rate is faster than 150. And what happens here is you see that the T's, or the little humps in between the QRS complexes, they begin to merge, so you have the P's and the T's merge together, so you no longer have the camel hump. And of course, the faster the heart rate, the increased demand is for oxygen for the body. So when you don't allow for a rest in the heart, you're not going to perfuse the coronary arteries like you should. So you're going to start to show symptoms of in-organ failure. Again, here's another little view of a P here, atrial tach. This looks like a different lead because, as you see, the P and the T actually looks inverted. So, have to look at what lead you're in to make sure that you're addressing the rhythm correctly. And pretty much throughout this course, we have looked at lead 2. So when you're looking in other leads, it may look a little different than it normally would from what we've discussed. Atrial flutter, this is when you let PACs go too long. Here's the things that can cause it. Usually with atrial flutter, again, your heart rate speeds up. You have a sense of chest pain because there is not perfusion of the heart muscles. And so you begin to start to show symptoms. Heart rate usually is between 220 to 350. And usually this becomes symptomatic in a patient. So remember, we talked about atrial flutter. That was the sawtooth appearance of the P waves, or it looked like a picket fence, which either way you want to describe it. But again, the cardiac demands are high for oxygen because the heart rate is so fast that it doesn't allow the perfusion of the body in general. If you let this go, you're going to have multi-organ failure, and again, the person could die. So atrial flutter, here's the different types of treatment. As a nurse, we do not do carotid sinus massages because, again, if you're in atrial flutter for too long, you can set up little clots in the atria. And when you do that carotid massage, if it is effective enough and it puts them back into a sinus rhythm, they could actually have a stroke. So again, when you're doing cardioversion or any kind of like carotid sinus massage or even the Valsalva maneuver, you want to make sure that the person hasn't been in that rhythm for too long. But usually if they're doing anything as far as treatment, most of the time nurses will do the Valsalva maneuver or they will give medications. But technically a nurse is not supposed to do a carotid sinus massage because of the potential for stroke situations. Again, here's another little thing of flutter, just to let you know that this slide just depicts like the equal P waves, and it looks like a sawtooth type appearance. Here's another pretty version of atrial flutter. Notice that in this slide you've got the P's come within the QRS, it comes before and it comes after. So again, it looks like a sawtooth as well. Now here's atrial fib. And this, if you let atrial flutter go, it'll turn into atrial fib. And then you've really got to worry about, treatment and cardioversion, especially when they become symptomatic, because this can actually cause people to have strokes. And this is when you're really going to feel the difference between the apical and radial pulses that I talked about a little bit. Again, heart rate, atrial rhythm could be anywhere from 400 to 700, which I don't even know if I could count that fast when I'm, palpating a pulse. But usually when they are not getting enough oxygen, they are very anxious. So if you see someone who is anxious, level of consciousness changes, that's a good sign that they're not getting enough oxygen. Here's a treatment. Again, you want to make sure that this is a scheduled kind of thing, especially when you're doing cardioversion, that you have the appropriate personnel and equipment available. Here's a picture of atrial fibrillation. On this slide, you can see where there's really no identifiable P wave. Some of those tall peaked areas you see, I could say they're P's, but they don't look alike, so they could possibly be T's. The ventricular rhythm is irregular, so therefore this becomes a mess in between the R to R. So we call this atrial fibrillation. There's another picture in the next slide of atrial fib. So just to let you see that.